Okay, that's 2 o'clock, so let's get started. Welcome everyone to the session today. For those of you that don't know me, I'm Michelle Miller and I'm the portfolio lead for the Community Care and Dementia portfolio. I'm really looking forward to this session this afternoon. So the webinar this afternoon is on person-centred care planning for people with dementia in hospital. And before I introduce today's speakers, I'll just run through some housekeeping rules for today. So your camera and microphone should be muted and your video off. So if that hasn't happened automatically for you, if you can just put them off. And this is just so that we've got as much bandwidth as we need to run the webinar today. We're going to have a Q&A session after the speakers, so you can submit any questions that you have for the speakers in the chat box, and we'll try to answer as many questions as we can during the session today. And lastly, the webinar is being recorded, and by taking part, you consent to this. The recording will be available on our website, and the link will be circulated to everyone who is registered. So this is the agenda for today's session. We've got a range of speakers, including Marie Innes, Jeff Dormer, Mandy Simpson and Con Gillespie. So thank you so much to all of our presenters who are joining us in the session today. And we'll close the session at 3:30 today. So I'll just give you a brief overview of our speakers and the contributions that they're going to make today. So Marie Innes is a Senior Improvement Advisor with the Community Care and Dementia portfolio at Healthcare Improvement Scotland. Marie's a physiotherapist by background, and she has led the Dementia in Hospitals Improvement Programme for quite a few years now for Healthcare Improvement Scotland, and it has a real focus on person-centred care planning. So Marie's an ideal person to be speaking on the session today and describing about the improvement programme. Jeff is from NHS Forth Valley, and Jeff Dormer is an AHP coordinator with the Older Adult Mental Health Service. Jeff is an occupational therapist and has worked for 17 years within social work and more recently in the NHS in both clinical and management roles and promoting rights-based approaches to rehabilitation. And today, Jeff will be sharing the experience of the occupational therapy service in improving the role of meaningful activity in Forth Valley Specialist Dementia Unit. So really looking forward to that session. Con is our other speaker, is a dementia consultant at the Golden Jubilee National Hospital, and Con brings 37 years experience with the NHS working in Greater Glasgow and Clyde across a variety of roles, and has been involved in supporting dementia care in acute hospitals, both within his role at the minute, but also within previous roles. And he will be talking today about Alzheimer Scotland dementia nurse and AHP consultants who have played a really key role in this work. The other presenter today is Mandy Simpson, and Mandy is a senior charge nurse in Glenrothes Community Hospital in NHS Fife, and her team participated in the Dementia in Hospitals work, so can speak firsthand on the work that the team has taken forward, where they've engaged with carers and family members to deliver more person-centred care to reduce stress and distress for people with dementia in hospitals. So hopefully that gives you a flavour of what's going to be in store for today's session. So I'll now just give a wee bit of an overview of the Dementia in Hospitals programme from Healthcare Improvement Scotland. So this work was commissioned from Scottish Government, and the aim was to improve hospital care for people with dementia. So why did we need such a programme? Well, we know that around 1 in 4 people in acute hospitals today will have dementia. People with dementia in hospital often have longer stays, they have delays in being discharged, they will often experience worse health outcomes with worsening of existing health problems and a decline in general functioning. So they may not be able to return to the level of independence they had before coming into hospital. And being in hospital is a very unfamiliar environment for people with dementia and can often trigger significant levels of stress and distress. In recent years, there have been lots of improvement work in hospitals, including initiatives supported through the Alzheimer Scotland Dementia Consultants. Generally, we know what works for people in hospital, but the issue we have is it doesn't always happen reliably. And there's various reasons for that happening. It could be down to staff shortages or a tendency to rely on specific individuals or a particular group or profession taking responsibility. So the improvement programme at Healthcare Improvement Scotland was planned to run from September 2019 to September 2021 across 3 different types of settings, including acute, community hospitals and specialist dementia units. But very early in the programme, we faced the onset of COVID-19 pandemic. As the teams were all based in hospitals, this had a significant impact on the programme, and we had to pause the programme a couple of times because staff were being pulled away in many different directions, including our national team as well in the responsive support during the intense COVID period. So the number of teams who participated in this work fluctuated because of that, with some teams having to withdraw completely and others pausing and then re-engaging in the programme. But despite all of that, by the end of the programme, we still had 6 very active teams working to improve person-centred care. And that work came to an end in March this year, and there's a really good evaluation report on our website which describes that in more detail. But Marie will speak eloquently around some of that work and give you much more detail about that. So just before we move on to hear a bit more about the programme, I wanted to pause for a second, and this is a chance to reflect and put some comments into the chat box. So if you were in hospital, what would you want the people supporting you to know about you? So just take a couple of minutes and pop into the chat box. If you were in hospital today, what would you want the people supporting you to know about you? So yes, what matters to me most and who's important to me is coming through your likes and dislikes, fears, goals, and worrying about my dog, yes. And yeah, really important to know that people's choices of food. So are you vegetarian or not? Food always comes up in these types of questions. And who's important to me? So the family members, the friends. A bit about background, hobbies, because all of these things can help keep people calm if we can have conversations around some of these. And need a window. So keep popping them in, these comments in the chat box, really, really interesting. Thank you. And I will pass over now to Marie Innes, who is the Senior Improvement Advisor for the Dementia Hospitals work and is going to talk about the improvement approach. So over to you, Marie.
Thanks, Michelle, and thanks everybody for putting all those things in the chat. It's really interesting to see the different things that people would find important, and it's really relevant to what we're going to be talking about today. So as Michelle says, my name's Marie Innes. I'm a Senior Improvement Advisor in the Focus on Dementia team and have been working on the hospitals programme for the last few years. So I'm going to talk a bit about how we delivered the programme from a national perspective, and then we'll get some of the people who were involved in participating in the programme to share some of their experiences. So for this programme, we used a quality improvement approach method called the Model for Improvement to test and implement improvements. And this is based on a really simple approach of using 3 questions to guide teams through their improvements. So the questions are, what are we trying to accomplish? What changes can we make that will result in improvement? And how will we know that a change is an improvement? And we'll now go into how we used each of these questions throughout the programme. So question 1, what are we trying to accomplish? And this is really about setting an aim for the improvement work. So we worked at the start with a range of stakeholders to agree the aim based on the priorities that were emerging during the pandemic. So the visiting restrictions that were in place meant that it was more difficult for staff to get to know what was important for people with dementia who were admitted to the wards, and therefore to provide truly person-centred care. So as a result, we agreed that we would focus on the programme on one priority, person-centred care planning. So our specific aim was that hospital care for people with dementia would be informed by a personalised care plan which reflects the strengths, needs, wishes and choices. And our theory was that this improved person-centred care planning would reduce stress and distress for people with dementia in hospital. So person-centred care plan is something that has been talked about for a long time. It's often something that's highlighted in hospital inspections as something that could be improved. So I'd be interested to get some thoughts from all of you on the call today before we talk about what our teams worked on the programme. So the question we have for you is, in your experience, what gets in the way of good person-centred care planning? Now, we're actually just going to get a little poll popping up just shortly, and if you could just type into that, it should appear just on the top of your screen and in the chat. And if you could just type in your response of what gets in the way of good person-centred care planning, it can be one word or a few words. Just start typing them in and we'll start to see them appearing on the screen. For anyone who's familiar with the word cloud that we're using here, you'll know that any words that are used repeatedly or more often will appear bigger. So we can see already that time is appearing in as quite a main issue. Staffing as well is popping up as quite a large area. Yeah, so lack of time, staff, lack of communication, lack of information, time restraints. Yeah, so a lot of very, very similar themes coming up. But if you do have the poll box on the front of your screen, you can just click on the little X and it will remove that so you can see the slides again. So we'll come back to some of that because, you know, we do expect that people will talk about staffing and time, and we'll be able to talk about what some teams did to help with that. So on to question 2, what changes can we make that will result in improvement? And this is about specific practical changes that we can make to the way we work to achieve better outcomes and results, and ultimately to achieve the aim that we set. So in this programme, we agreed on 3 main areas that teams would need to work on to achieve that aim that we set. So these were that care plans are completed and documented, that the person and their family and carers are involved in the process, and that staff are supported to use their person-centred approaches in practice. So we provided teams with various types of support to increase their quality improvement knowledge and skills and share with each other what they were learning. So the activities that we did throughout the programme included learning sessions. So these were focused on teaching quality improvement methodology to the teams, and there was really a space for teams to share their progress, exchange ideas and kind of help each other out along the way, really. We also did monthly coaching calls with teams, and we visited the teams on site as well. That was a bit more limited than we normally would because of COVID, but we did that where we could. We provided a closed Microsoft Teams channel. So again, we provided all the tools and resources for teams, and again, it allowed teams to communicate with each other. The programme was also supported by a wide range of stakeholders, including people with lived experience, and they formed a delivery group which provided advice and guidance on the programme development and delivery. And this really made sure that the ongoing delivery of the programme was informed by expertise within the system. So we're constantly checking in with the group to see if what we were doing was the right thing at that time. The programme was delivered in partnership with the Alzheimer Scotland Dementia Consultants, we've mentioned before, and as Michelle says, we have Con Gillespie on the call with us today who'll tell us a little bit more about their role in the programme and also how they could support you in your work. So the teams involved used the quality improvement tools to test and implement a range of improvement ideas using Plan, Do, Study, Act or PDSA cycles. And as we've said, we'll hear from a couple of teams shortly about how they made those improvements. We've already mentioned that the programme took place within an extremely challenging time for hospital teams. So we really tried to support teams to look at what really small changes they could make within that context that they were in. And there were often significant staff shortages and time pressures, and many of you have mentioned that when you said that's what gets in the way. So many of the teams focused on using a document called Getting to Know Me, and interestingly, in your response to the first question, many people were saying about what's important to me and getting to know me as an individual. So teams focused on using that document to gather person-centred information about individuals, and they tested ways and introduced processes to make sure that that document was completed reliably. Some teams created life storybooks or memory boxes to support meaningful activities. Teams also worked on increasing staff confidence and competence in using person-centred approaches and involving more team members in their care planning process. And one team in NHS Dumfries and Galloway focused on the fact that not all members of the team could easily access the personal information held in the notes. So they developed a poster to stay by the patient bedside so that all team members, including volunteers, could use this in their interactions and conversations as part of goal setting. And you can see the poster on the slide here. So on to question 3, how will we know that a change is an improvement? And this was about collecting data and evidence to demonstrate the difference that teams were making. And one of the areas we saw an improvement was in the knowledge and understanding of quality improvement. Teams who attended the learning session and coaching calls gave very positive feedback. They said they'd used their new knowledge to understand how effective their current processes were and to come up with ways to improve them. And there's a quote here in the slide that I previously knew nothing about quality improvement and I have learned a lot. It's given me confidence to consider using quality improvement in other areas. And as well as that, the nature of an improvement programme is that it allows teams to learn and share with others working on similar improvements. And as we've said, the activities such as the learning sessions, the team pages, allowed people to network and make connections with other teams. They shared examples of what they'd been working on, and they had the opportunity to question each other to inform their own work. And there were many different areas where we saw improvements as a result of all this testing new processes. And the most significant improvements were around reduced stress and distress. So for teams who gathered the personal information from families, they reported examples of less agitation, more engagement and activity, and there was a reduction in incidents reported as a result of this. We also saw examples of reduced falls, and we'll be sharing a specific example about that just shortly. So another quote from one of the senior charge nurses involved in the programme, it was so rich, the data, we were able to link in the stress and distress data with less falls, less PRNs, and that's the first we've been able to do that as a ward team. We've shown real positive progress here. So before I talk any more about the programme, I mentioned there about reduced falls, and what we did is we got a senior charge nurse from one of the teams, Lisa McDowell, from the Jubilee Hospital in Grampian, and we recorded a short interview with her on one of our podcasts to describe the work they had done and how they had achieved that reduction in falls. So rather than me describing it to you, I'm going to play the short part of the podcast. It's only a few minutes, and it'll allow you to hear Lisa describing their work.
I'm joined by Lisa McDowell, Senior Charge Nurse at the Jubilee Hospital.
Sorry, I'm just pausing that there because I've seen a couple of people saying that they can't hear the podcast. I'm just going to try and start that again, and if you could just type in the chat if you can hear it.
I'm joined by Lisa McDowell, Senior Charge Nurse at the Jubilee Hospital in Grampian, to tell us
Okay, so I do apologise. I see that some people had some issues hearing that. I know that quite a lot of people did hear it and some heard bits and not others. So apologies for that. There's always a risk when we try technology. But we have posted the link to the podcast in the chat and where that section is. And I've noticed in the chat as well that Lisa is actually on the call today, which is great, but we've taken a bit pressure off for having to tell her story again, and she can just listen back this time. But I would encourage you to play the podcast if you haven't heard it today in full. So yeah, a really good example there from Grampian about how making relatively small changes can have a really big impact on the care for and the outcomes for people. So as well as the benefits for patients and their families, there were many examples of the impact the programme had on the staff teams, so including staff morale and culture. So some teams reported that there was a change in culture with a shift in the traditional thinking around the use of activity, and there were reports of improved morale and better team working. So for example, we had a quote that said morale was low. I think the fact that we were trying something else, it helped. It was something positive and moving forward and not anything to do with COVID. And we heard that a few times through the programme. There was also a recurring theme about job satisfaction and teamwork, and some staff reported that it was more satisfying to deliver more person-centred care. And interestingly, just going back to the question we posed earlier on, there were reports of saved time for staff because of the reduced levels of stress and distress. So again, that's the thing that normally would get in the way, but actually by making these changes, people were finding it saved them time as well. And another quote from a senior charge nurse: the project for me has been life-changing as a new senior charge nurse to implement these changes that I knew needed to be done. During the programme, the Mental Welfare Commission also visited 2 of the wards involved, and they gave very positive feedback, including noting that the project had led to significant increase in both the completion rate and the quality of the information that was recorded, and then how it was subsequently incorporated into the person-centred care plans. And they said, this quote on the slide, that they would recommend these care plans as exemplars of good practice. So again, the team were really pleased to see the progress they'd made in that way. In terms of overall success factors for the programme, there were a number of factors that were really important in achieving the outcomes, particularly within this context. So firstly, the partnership approach with the Alzheimer Scotland Dementia Consultants we've mentioned a couple of times, and as I say, we'll be hearing more about that. Taking a partnership approach with families and carers was absolutely vital. A key focus of the work, as you've heard, was working with families and carers to identify and use the really personalised information more consistently to make sure that all interactions and activities were person-centred and meaningful. Whole team approach. So several teams made sure that the whole team was involved, and this included healthcare support workers, administrative staff, allied health professionals. And this made a big difference, where person-centred care planning was then seen as something everyone could and should be involved in. It allowed teams to spread the load and benefit from the range of skills and expertise in the team. So, for example, in one team, occupational therapy students led some of the PDSA tests, and this helped them to both increase their knowledge of quality improvement, and it also allowed the team to continue with their improvement work even during a particularly busy period. Another team involved the ward clerk in giving out and following up the return of the Getting to Know Me documents. So lots of examples of how to use the kind of wider team. Flexibility when things were difficult. So here in Healthcare Improvement Scotland, we really had to change the way that we would normally run a programme like this in the context that we were in, just to make it as easy as possible for teams to stay involved. And similarly, the teams were really flexible, and they would pause their work when things were particularly difficult, for example, with staffing issues. Many of the changes that teams made seem relatively small. They didn't require a lot of additional time or staffing resources to get started, but they did require the team to get together and really plan how to make sure that their changes were happening reliably. But the really important factor was that they continued to do that within the context of the busy, high-pressure environments, testing small changes whenever they could. So really the big message was to pause when you need to, but don't stop. and quality improvement approach, of course, which is what we've been talking about. So as I've described, the whole programme was based on quality improvement methodology, and using this approach to starting small, repeatedly testing and collecting data to check if they were making any difference. And these were all really the absolute key factors in the success of the programme. So what's next for our hospital improvement work? So we'll be using the learning from this programme to support the implementation of the recently published dementia strategy and the SIGN guideline, which is due to be published next month. We'll also be sharing the learning across Scotland through a range of channels, including our learning system activities such as this and social media. We have our website, which has been updated, and it includes the full programme report, the change package, and the 6 high impact changes that we came up with from this programme. And we'll be adding a link to the web page, so there it is already in the chat box, so you can have a look at the information in more detail there. Within those pages, we have a Dementia in Hospitals toolkit, which was developed after a previous programme, and we will continue to update that based on everything we've learned. And we will, of course, continue to link with other national programmes and partner organisations to keep making improvements within hospitals. So that's the end of the summary of the hospitals programme, and I'm just going to pass back to Michelle to introduce our next speaker.
Thanks, Marie, and thank you for giving such a comprehensive overview of the programme. And there's so much to cover in such a short time. But if you do have any questions, please pop them into the chat box and we will pick them up with Marie later in the session. I'm now going to move over to Jeff. So Jeff is the HP coordinator in NHS Forth Valley and is going to talk about meaningful activity for people with dementia. So over to you, Jeff.
Good afternoon, everybody, and thanks, Michelle and Marie, for inviting me to come along. I'm just hoping, can everybody see the slides okay? Yeah, get a thumbs up for that. Yeah, okay, right. That's great. So as Michelle can introduced, my name is Jeff Dormer. I'm a HP coordinator in older adult services for NHS Forth Valley. Our service is made up of physiotherapy and occupational therapy, working in both inpatient and community settings. So today I'm really going to come and kind of share the story of the occupational therapy service in terms of our involvement with dementia in hospitals. We're going to look at a kind of storyline in terms of the presentation today, and that's really just to look at the kind of power of storytelling and how we captured the kind of information and the data from the project work that we did. So I'll be kind of setting the scene, talking about the everyday, looking at what the project change was, some of the difference it made, and then some of the changes that followed on from that. And also in traditional style, we'll talk about the happy ever after beyond that. We were quite late to the HIS project in terms of the kind of pauses that happened throughout COVID. So most of this work was carried out in 2022. One of our occupational therapists, Karen Dick, moved in terms of our rotation to our Ward 4. And really we've seen this as a really good opportunity to try and be involved in the project work and contribute to some of the work going on. So just to set the scene, Ward 4 in Forth Valley Royal Hospital, it's a 16-bedded acute assessment unit for adults with dementia. We have an MDT team there that's based around occupational therapists. We've also got Alzheimer Scotland dementia consultant, nurses, activity coordinator input, and also psychology input. So as I say, we were kind of joining the programme fairly late on, so we wanted to be part of that kind of MDT approach and see what our contribution could be. And again, the focus was really looking to develop the opportunities for person-centred care through use of meaningful activity, and just what was the unique offer in terms of occupational therapy and what we could provide. So that every day we were, as I say, the ward was part of the Dementia in Hospitals Collaborative. They engaged in quite a bit of work already. The OT that arrived into the ward was actually on the Dementia Specialist Improvement Lead course. So that was a real kind of opportunity and motivation for us to be part of a kind of quality improvement project. Also within our kind of older adult AHP service, we were really keen to try and improve our quality improvement skills, our capacity and experience and that type of work. So getting to know me was one of the things that was in use on the ward to good effect, and also in terms of our psychology colleagues, they were leading with stress and distress formulations. So a lot of that work had been fairly embedded in terms of the everyday practice that was going on. And in terms of occupational therapy, we had quite a history of using the pool activity, and that's really looking at occupational profiling on different levels of ability for each patient. And it's a kind of strength-based approach for those who are not familiar with it, and really looking at 4 different areas of activity for patients. Those are planned, exploratory, sensory and reflex. So looking at those 4 categories, we were profiling each patient's ability to engage in activity on that basis. But what we were finding was that some of the language and the jargon within that model didn't always sit right, or in terms of our colleagues, and we were trying to embed that approach throughout the ward, but with kind of limited success. So we tried to think of a new approach and something new that we could try. And in terms of our kind of own AHP approach, this is our Connected People, Connected Support, our national kind of model for AHP work in dementia. And again, it really focuses on the importance of meaningful occupations, valuing the role of everyday activities as therapeutic interventions, and ensuring that those are person-centred and individually tailored, and that they provide opportunity and choice in activities. So again, this was a real kind of driver for us in terms of our approach in terms of the ward. And within that Connecting People, Connecting Support approach, we've got 4 ambitions: enhanced access, partnership working, an AHP workforce that's skilled in dementia care, and innovation and improvement. So for us, that sat really well, working in collaboration with HIS, try and combine the ambitions of our kind of work and national programme. So in terms of the change, what we were looking to do in partnership with the support of Marie, Stephen and Karen from HIS was really to tie down what was our aim going to be, what were we going to do. So our aim was for patients in Ward 4 to be engaged in meaningful activity to reduce stress and distress and provide a sense of purpose to the day. In terms of measurement, we looked at how that was being documented in Care Partner, which is our kind of recording tool at Forth Valley, and we were really looking for evidence of meaningful activity and what was the kind of patient outcome attached to that in terms of engaging with that bit of activity. We looked at we carried out a number of PDAC cycles. So the change that I'm going to explain to you is looking at an activity plan that we developed for each patient. So in terms of our PDA cycles and that QI approach, we really just started small, as Marie was saying, and looked at developing that template, got some feedback from the wider MDT team, introduced the concept to staff. We also produced a personalised activity plan for one patient, and then got feedback on that one, and then moved on to a second patient and carried on in that fashion, really to try and develop our kind of knowledge and impact of what it was we were doing, but doing it on a small scale and learning from each PDA cycle. So as I was saying, the getting to know me form was really quite embedded as part of the kind of wider team's work. And one of the quotes there was from our senior charge nurse, who felt that the collaborative was very positive for helping to change the culture on the ward, to look at improving and understanding stress and distress symptoms, and how getting to know me completion could really help with personalised care, and focusing in on orientation boards completion. So we had orientation boards at the side of every patient's bed that all the information that was gathered and the getting to know me was transposed over to that orientation board. And also our psychology colleagues were looking at stress and distress formulations as well. So in terms of our kind of contribution to that, we really wanted to make sure that whatever we were doing was aligned to that and was collaborating with those other efforts. We didn't want to introduce yet another form that would not be working alongside that. So this was the change, the example that we came up with. And that was just an activity plan that was fashioned in the same way as the Getting to Know Me document, and really had kind of 3 simple questions on it, really looking at what do you like to do to spend your time, what is your desired outcome, and how would you like staff to support you. So in terms of developing this form, the OT would carry out an assessment with the individual, looking at the information that was gathered from a range of sources, including the Getting to Know Me, and then they would look at a variety of different activities, utilising sometimes the pool profiling, and also through the use of grading and adaptation of activity and some activity analysis. They would complete a personalised activity plan, would be created and recorded here in that first section. We also looked at what were the desired outcomes, and that was really relating to our wish to try and embed some outcome focused practice, so that whatever we were doing was really strongly related and aligned to the outcome for the patient. And then the last section was how I would like staff to support me. So this was really just some additional information on what would really support the patient to engage in that particular activity. And it wasn't just around activity itself, it would also include the kind of general environment, what would be supportive in terms of, is it a one-to-one in a kind of side room, or is it more of a kind of group activity that would be within a communal area. So all that information was included in there, and it would also include any particular needs around sensory needs or equipment that might be required to facilitate that activity. So the difference it made in terms of some of the feedback and observations that we made, it was documented in care plans quite often by nursing colleagues that the use of the meaningful activity identified in the activity plan had reduced the need for PRN medication, and that was really part of our hope, is that the meaningful activity would offer an approach to the sort of non-pharmacological management of stress and distress. And certainly the feedback from staff and the recording and the care partner evidence that to a degree that the engagement in the meaningful activity did reduce the need for that. Also, we had evidence that the meaningful activity that was identified in the activity plan were being utilised by the wider staff team, so it wasn't just sitting with our kind of occupational therapy service and our activity coordinator, but the wider MDT team. There was evidence that they were utilising some of these activity plans. Also, our Mental Welfare Commission inspection report acknowledged the contribution of the OT service in promoting the use of meaningful activity, and also helping to support transition into community hospital and or care home, which I'll go on to chat about next. And also the general positive feedback from the MDT on availability and access to meaningful activity. I think there was a real kind of focus on the provision of that and how it could benefit the patients on the ward, and that was really well received by colleagues. So in terms of some of our kind of qualitative feedback that we got to inform our project, as I say, we quickly figured out that the information that was gathered as part of the kind of activity plan was really helpful in terms of supporting that transition from the acute assessment unit into our kind of community wards, where patients were quite frequently transferred to awaiting discharge home or moving on to another care setting. These community wards had significantly less OT input in terms of the acute assessment unit. So what we were finding is that the activity plans were really well utilised in terms of our OT assistant colleagues and activity coordinator colleagues in the community ward. And these are just some of the kind of feedback that we got in terms of the information and the assessments carried out on the acute assessment unit were transferring well over to those community settings, and really helping to engage in terms of that meaningful activity approach. And this is just, I think, another really good example of, you know, a patient who was really quite disengaged with the offer of kind of occupation and activity. And through the use of the activity planner, the OT assistant was really able to engage the patient in terms of that activity going forward, just by a few key points that they developed from the activity plan. So further changes, we've developed a guidance note for the activity plan that really just kind of guides whoever's looking to use that in more detail. The shorter length of stay in specialist dementia unit we found was impacting on the ability for information gathering and creation of the activity plan, and again that was key in terms of that transition onto a community ward or care home setting. We also found it was quite high clinical demand for other OT assessment and intervention, including discharge planning, that did in time impact on our ability to engage with the activity plans and use of the activity plan in other settings. So we were really keen to see where this transition could go in terms of promoting continuity of care, and could these activity plans follow on, because quite often with the length of time involved in terms of patients moving through that journey of acute assessment, community wards and onwards, some of that key information could be lost. And just finally, in terms of our happily ever after, so there was a real sense that there was those kind of benefits of an MDT approach to meaningful activity. So that shift in traditional thinking about the use of activities as being group activities, timetabled, to a move to a real personalised, sometimes shorter one-to-one meaningful activity. The role of getting to know me was really well embedded in terms of a personalised approach to care. And just in terms of future, we are now looking at a development of an MDT integrated person-centred care plan, and is in development on Ward 4 that will involve the various services all participating and contributing to one integrated person-centred care plan as the ambition going forward.
Jeff, thank you so much. That was a brilliant overview of all the great work that's happening in Forth Valley using Getting to Know Me, and generated lots of discussion in the chat box as well, which we'll pick up later. We're now moving over to a break, so we've got 5 minutes. So if we can come back at 2:52, just enough time to get away from the screen and stretch your legs, and we'll see everyone back at 2:52. Thanks very much again, Jeff. Okay, welcome back everyone. Hope you had a chance to grab a quick drink and stretch your legs. I'm now going to hand over to Mandy Simpson, who is the senior charge nurse from Glenrothes Hospital in NHS Fife, Mandy's team were part of the Dementia in Hospitals Improvement Programme, and Mandy is going to share some of the work of her team. So over to you, Mandy.
Good afternoon.
And if you just put your camera on, Mandy, if you can.
Okay. My name is Mandy Simpson. I'm the senior charge nurse at Ward 3 Glenrothes. Ward 3 at Glenrothes were involved in the Dementia in Hospital Collaborative before I started. When I came into post being a dementia champion, I was really keen to keep the work going that I had been trialling. So for us, it was about looking at the getting to know me's. Most of our patients are transferred from the acute, and what we were finding was these documents were not in place, or they were very badly completed. So for our initiative, we wanted to make a quality improvement board, which I'll show you just now as an example. So we completed an example, a fully completed example, to try and get relatives to provide us with as much information as possible, which could be integrated into patients' care plans or what matters to me, that went above their bedside. We use the PDSA cycles on a regular basis to review the data that we could collect coming in from the acute, or what we were implementing on the ward to make that improvement. For us, it was about involving families, it was engaging with them, to encourage that patient-centred care, because they're the ones that could help us identify any traits that the relative may have that we could pick up to reduce stress and distress, or any meaningful activities we could implement. So that's where we were at. The change we have now integrated the getting to know me's into the admission packs. They're given out as soon as a patient comes in. We engage with the families on admission. We now phone families if they're not in to visit when the patient arrives, just to collect some information. Patient care plans have now become really patient-centred, and they've helped us identify meaningful activities. So we try and encourage for that relative. So I'll move on to the next slide. So this was a gentleman just from using his getting to know me, that they'd identified that he liked his mouth organ. We asked the family to bring it in to help reduce his stress and distress. This was actually very positive, because another gentleman in the bay also liked to play a mouth organ. So his family brought his in as well. So for us, it was just, the getting to know me's have improved greatly. And we'll continue to do that, continue with that work. Sorry, I'm not very good at doing this. A wee bit nervous.
You're doing absolutely brilliant. Just take your time. You're doing great.
Yeah. So for us, the getting to know me's are now integrated. They're there for every single person, whether they have a dementia diagnosis or not. Because if patients become ill and have a delirium, it means that we've already got that information to be able to provide that patient-centred care for them. So we will continue going forward. Thank you.
That was brilliant, Mandy. And I know this isn't your normal day job.
No.
So I know it's not easy, but you did a great job, and thank you so much for the overview. And you were getting loads of love hearts. I don't know if you saw the love hearts flying across the page, but you got a huge huge gratefulness from everybody on the call, and you generated lots of discussion in the chat box as well. So it's a really nice example of using Getting to Know Me, not only for people with dementia, but also for others on the ward who would benefit from the staff knowing much more about the person. So thank you so much for sharing. We're now going to move over to Con, and we will take questions at the end. So I know there's a lot of questions in the chat box, but we will pick up on them at the end of the presentation. So as I said earlier, Con is one of the Alzheimer Scotland dementia consultants based at the Golden Jubilee in Glasgow, but a huge wealth of experience of working in this area, and is going to share some of the work of the Alzheimer Scotland dementia consultants. So over to you, Con.
Hello, Michelle. Thank you. I'm just looking to take control, but I can't see the button there. Would somebody be able to work through slides with me when I'm going on?
Yeah, I think we've just lost the slides for a bit, but hopefully Emily will be up.
That's okay.
I'll in the background.
I can batter on. Don't worry
Here they're
about
coming.
it.
They're coming up now.
Okay. Right.
You should be able to take control now.
Yes, I think I'm now. Okay. Okay. So thanks very much, Marie. Thanks very much for inviting me along today. As has been said, my name's Con. I'm the dementia lead for the Golden Jubilee Hospital in Clydebank. It's a national hospital for waiting time initiatives, I suppose focusing particularly on orthopaedic, general surgery, ophthalmology and interventional cardiology and thoracic surgery, as well as heart transplant. I'm here to, I suppose, represent the consultant group, the dementia consultant group today, and I'm probably going to start off with, if I can, and that's so
if you just click on to slide 38.
Right.
Do you want me to do that for you, Con, while you're speaking?
Yes, if you could do,
to
yes. I'm not very good at multitasking.
No, it's not easy.
Thank you. Oh, thank you very much. So just to say, just a kind of, I'm trying to have something kind of comprehensive to describe the Alzheimer Scotland dementia consultant role. We're there to work to improve care, to enhance care and transform the care experience of people with dementia and their families. Improving hospital care is a key focus of the role, and I think maybe see if we can. Oh. Yeah, so the focus is very much on hospital care. There is other aspects of the role which are worth highlighting. We also use our strategic professional positioning and dementia-specific expertise to influence and inform dementia care, both at a strategic and operational level across specialist dementia care facilities, acute services, community hospitals and care homes. So just a kind of exhaustive highlight of that. So most of the time we do spend directly involved in improving care within general and community hospitals and caring for people with dementia, but we also have an impact with patients and families and looking after care in mental health and other healthcare settings like care homes. Should just mention that most of the dementia consultants have a nursing background, but we also have a number of AHP dementia consultants as well. The Alzheimer Scotland launched the Specialist Dementia Nurse Programme as long ago as 2006, and over the kind of years after that evolved the role of the dementia consultants, and these posts were created across all boards within Scotland, and by 2015 every health board in Scotland did have a dementia consultant, Alzheimer's Scotland dementia consultant in post. The group work very closely both as a group. I think it's a strong group. We meet formally every month, but we also interact on a regular basis. We try to create a standardised approach to all aspects of dementia care from a strategic and policy point of view. We have an input into areas such as the dementia strategy that was mentioned earlier on by Marie, recently came out in May this year. At the moment, there's various groups which are looking at how we, I suppose, deliver on what's in the strategy, including areas such as workforce and education. So the dementia group consultants do have a clear vision of what the work they do. As I say, we regularly meet to kind of drive forward national improvements in policy and ensure we have consistency in all aspects of care. I think probably on a more local level, we're also trying to have a consistency about the systems that we are promoting and creating and developing within acute care settings. For instance, we have been working on a dementia education matrix, which is designed, I suppose, to ensure that the level of education that's available is consistently available throughout Scotland. There's a lot of materials, as you probably know, on via NES. There's some local education that we do covering areas such as stress, distress and delirium as well. Currently, the funding for dementia consulting is shared between Alzheimer Scottish Government and NHS boards. We'd also, I think, kind of going back to just we aim to kind of influence within our own boards, and if we look at some of the more breaking down some of the roles and responsibilities in the context of the hospital improvement programme, there is a key leadership role in providing dementia care within all NHS boards. We were delighted to be involved in the programme and provide leadership and support to all the teams, despite the challenges within that. And we'll talk a wee bit about that when we go into how we move forward with that. As we say, we do contribute to strategy, policy and standards of care. We usually have representation in all key strategic and policy-driven groups across Scotland, sometimes more than one of us. And again, we're trying to ensure we have robust systems to deliver optimum care in all clinical settings. From my own point of view, I'm fairly new to post, so one of the things I'm trying to do is whereby we always good availability for staff and for patients and carers, for anybody who comes into the hospital with dementia to access expert care as soon as possible. We do have dementia champions, as you know. There's about 1,000 in Scotland. We've got about 15 in our board, and we've got a group which again is designed to help and support ward staff and patients in delivering any aspect of care. We also develop link nurses within wards, again to try and develop and make sure that we're utilising all the tools required to improve and maintain standards of care. And of course, I think again within our roles, very much a case of providing expert and advice and support in improving care to clinical teams on a day-to-day basis. So what we learned from the Dementia Hospital programme from a Alzheimer's Scotland Dementia Consultants perspective, I think the first thing to say is it was extremely challenging. I don't think I need to really kind of develop that too much. The challenges throughout COVID and even immediately after COVID, I was very aware of because I was working within a kind of unscheduled care environment, and I think the person-centred visiting and providing support for people with dementia in itself was hugely challenging when we're trying to balance the concerns with COVID and the implications of that. However, as you've heard today, some really great work and some fantastic small projects, which again emphasising how important it is to employ person-centred care in people with dementia. I think it's very clear from the experience of dementia consultants who appreciated that staff really require a lot of support, particularly when there is lots of challenges around staffing. COVID recovery and staff shortages to make sustainable changes. And I think we're very kind of conscious as a group that that's something that we should be providing and continue to provide leadership support wherever we can. I think again demonstrated is the motivation and commitment of clinical teams, highlighted like by Jeff and by Mandy particularly, just about the amount of work that's gone in to try and install good person-centred care and improve systems that we have. I think the way forward probably is smaller quality improvement projects. I'm certainly a great advocate for taking small quality improvement projects, applying PDSA cycles and supporting individual teams, dementia champions and others to try and improve care and building that. I think doing anything in a large systemic way is often challenging, and obviously I think that's the main goal, that we have that consistency in standards across all hospital and clinical care settings. So how can we help? So we have got dementia champions in all areas. As I say, we've got 1,000 across Scotland. I think there may be some areas that have needed to refresh where the dementia champions are. Certainly need to do that, but they are expertise. Sometimes need a bit of refreshment with their expertise that can provide help and support for families and people with dementia across Scotland. We, as I say, the dementia champions and the dementia council are available, and I think one of the important things I'd like to get across today is that the dementia consultants are available to contact for anyone. Certainly dementia champions are usually a more immediate kind of accessibility, but from a point of view, dementia consultants are delighted and are really engaged in trying to improve care in every aspect as a central part of the role. And the next slide will give you, and give you all the kind of email contacts of each of the dementia consultants across the country. So again, aiming to hope and share and learn and influence practice and continue to do that with the local area with a view to also sharing that experience across the whole of all the clinical settings. So just to finish, just a list there, which again was being recorded and the slides been available. If you want to contact anyone in your local area, please contact them and don't hesitate. If there's anything at all you want to ask on the back of my presentation today, please do so. And thank you for your attention. Thank you.
Thank you so much, Con, and I know you're quite new to the role, but obviously have a huge amount of expertise and experience over the years as well. So thank you so much for sharing all of that. Now is an opportunity for you to ask any of the speakers any questions. There are quite a few questions and comments in the chat box. We'll do our best to answer most of them, but if we're leaving something unanswered, or if we run out of time, we can come back to you on that. So we'll just have a run through of some of the questions. One that I picked up was, we heard quite a lot today about the use of getting to know me on the side of the bed, so having that displayed. And Maureen in particular was asking if there were any issues with confidentiality in sharing people's likes and dislikes and the content of their getting to know me in a public area next to the bed. So I don't know if any of our speakers want to come in and answer anything on that. Con?
Yeah, I mean, I must admit, I think getting to know me is a bedside document. I don't think it works in any way. I think it's less effective if it's filed away somewhere or is away from the patient's bedside. To me, it's always been there to inform and advise anybody who's caring for the person in the bed, and it needs to be easily accessible. Now, I appreciate there is always confidentiality issues. I think they can be negotiated, they can be discussed with patients and carers, and if there is an issue, then obviously that would be accounted for. But in general speaking, it's designed to be a positive document to give information to help provide individual care to the person with dementia, or the vulnerable adult, as it often can be used in other settings as well. So I'm very clear in my view about that. I'm happy to anyone to give a counter argument. I think that's important, that's accessible.
Thanks very much. And obviously that would be shared in conversation with family members and people with dementia themselves. Jeff, I don't know if there's anything else you wanted to add to that at all.
Yeah, I think it just is conscious is kind of professional discretion, isn't it? And being aware of what you put on a board is appropriate, but also that you know, it can actually provide quite a lot of reassurance in terms of visiting family members, seeing signs that the person that's being cared for is actually well known, and certainly for staff in terms of the work we undertook, you know, it meant that there was certainly for like the meaningful activity section of it, there was clear information about, you know, what you could try fairly quickly to try and alleviate some oncoming symptoms of stress and distress potentially, you know, because if you've got the patient there in the moment, you know, to drop things, go away and look at a file, come back, you know, it's not always that practical, but just having that information, key points I think that are available to the staff team, the MDT, really help people to kind of use their toolbox effectively, you know.
Great, thank you. Marie?
Yeah, and thanks both for answering that question. And it was something that came up at the very start, in particularly NHS Orkney looked into it, and I see that Gillian has posted in the chat to just confirm that the document belongs to the patient, and if there are clear guidelines in place, it can be shared in return. And that was something that people did identify as part of the issue, was where things weren't shared, if it was filed away in notes, the team then weren't accessing that information and not using it. So yeah, I agree with all the comments there.
Really helpful, thank you. And there was a question in the chat box about would it be helpful to have a list of dementia champions across Scotland, and Christine, who is one of the Alzheimer nurse consultants down in Borders, has put a comment in to say you can contact your local dementia consultant who will advise who your dementia champions are in your board area. So that's really, really helpful. Are you picking up on other questions, Marie? Has anything popped out? There's quite a number in there. So let me just check.
There were quite a few. I've noted a few down, and there was one comment about that these documents have been around for a long time and not fully used due to time. What would be the difference in the success in using them now? And I'm hoping that some of that's came out through the course of the webinar, and that was part of the issues, that the documents were there but they were either getting filed away or they weren't getting completed. And I think it was down to using that really systematic quality improvement approach of looking at why were they not getting completed, what was it that needed to happen to make sure they were completed, and not just completed but shared with the team, and the ways that we've described there, whether it's by the patient bedside, but also then about how does that then inform practice and get used in the person-centred care plans. So that was what teams were really looking at, as making sure that the processes to make sure that happened reliably happened, and they did that using their small tests of change. So yeah, absolutely right, they've been there for a while, but just it's just about taking that really consistent approach to using them.
Yeah, really powerful, and quality improvement does lend itself to that. And we heard a really powerful quote from Jeff. I think it was one of your senior leaders within Forth Valley, talking about that actually through the work you had done was impacting on the culture of the ward area as well. Do you want to say anything more around how that person-centred culture was emerging as a result of the work you did?
Yeah, certainly, because I think we had a kind of traditional approach of, I think it's also just to do with kind of shift in patient presentation as well, where, you know, whereas years ago we had that kind of scheduled programme of activities that maybe served for the time and the moment there, but actually what we were finding was that levels of engagement were actually quite poor. So it was about shifting that kind of sense of kind of planned routine activity and actually making it more personalised, and in particular people's kind of sense of it doesn't always have to be doing something, you know. So sometimes even just a one-to-one chat or reminiscence is equally meaningful as actually doing an activity that produces something. So again, we've been using more technology as well in terms of YouTube and different kind of videos and things for reminiscence. So there's been a kind of real change in terms of that, more focus on a one-to-one approach. And I think just through trial, staff are finding that, you know, the responses and the engagement and those offers are much improved. So I think that was a real win for us in just terms of shifting that kind of weekly timetable of kind of pre-planned activity, which, you know, some people enjoyed but wasn't for everybody. It was actually moving to a more one-to-one approach and having that flexibility that, you know, if you tried that activity in that particular time and that morning, if it wasn't successful, then, you know, don't abandon it. You know, it could just be that you need to change the approach or change the time and or how the way it's presented. So I think that was a real kind of shift.
That's great, thank you. And Jeff, as you were speaking, somebody put in the chat box if you were able to share some of the tools. So they particularly liked your activity plan. I think it was Doreen had said, are you able to share any of those? And we're happy to share with
Certainly,
with the participants of today, both the recording and the slides and any resources that have been shared in the session today. I also saw Diane's comment that she's so heartened to see such high profile use of the Getting to Know Me document, and that she's been an advocate, like many I'm sure on the call, of this for many years. And what she's saying is a good Getting to Know Me provides us with a person-centred plan of care for our patients, and helps with discharge as well as the time that people are actually in the ward itself, and can be really effective in avoiding readmission. Mandy, I don't know if you wanted to say anything at all around, you've obviously incorporated the Getting to Know Me as part of the admission documentation. How did that land? How were you able to influence your colleagues to do that? Was it an easy sell?
It actually was quite an easy sell because we also use What Matters to Me board above the bedside. It was really good and helpful to get information from the Getting to Know Me to complete that. So it was integrating a bit of both. So no, the staff really enjoyed participating in that and taking it forward.
Mandy. Marie?
Yeah, I just wanted to, I noticed there was maybe 2 or 3 questions or comments as well about what were people doing when there weren't family or carers involved or able to help with the completion of the Getting to Know Me. And certainly for the teams that were involved, that was one of the main focus. It was one of the areas that we were focusing on, was about engaging families and carers and trying to, particularly at a time when there was less contact than there had been because of the restrictions in visiting. So that was a focus for the teams, is about working with families. I don't really have any other specific examples of teams that we're looking at when there wasn't family, but I do notice that Tracy has put a comment, Tracy Gow from Forth Valley has put a comment in the chat around that as well. So it was just to pick up on that. She was saying that it's not always the family or next to kin who fill them out. It's the person who knows them best. It's not the first time I've contacted home carers or even the local barmaid to find out information to help fill them out. So yeah, it's just kind of looking at that bigger picture. But where do you get the information? You know, often it will be the kind of next to kin family or people who are visiting, but it's just about looking at where can you find out everything you can about the person that might help with their care.
Thank you, really helpful. One of the other comments today was around and was covered by a couple of the presenters about the job satisfaction that and the staff morale that people have felt through feeling like they're doing a good person-centred job. And I wondered, I know Marie, that was something that came out quite strongly in the evaluation from the work, but others have mentioned that as well. Is there anything you would want to say around that?
Yeah, it did. I mean, it was definitely quite a few things came out about staff, and obviously we were looking at outcomes for the patients and families and carers. But there was certainly in the interviews we did with people involved, there was a lot about the morale, about the job satisfaction. Obviously, I shared a couple of quotes there. But yeah, it was just that whole. It was much nicer for staff. People were saying it was so much, just to spend that. I mean, that example that we heard from NHS Grampian about sitting and playing dominoes with a gentleman and just getting to know him and spending that time, that actually had such a big impact on the outcomes for him as well. So staff were definitely finding that was a much it was a nice way to work as well. And as I say, we did also hear that it was saving people time as well, which is always a bonus, really.
And I know Lisa is actually on the webinar today, and I don't know if you're still with us, Lisa, if you wanted to share any reflections at all on being part of the programme.
I'm not sure if we're able to get Lisa off of mute. Is anyone able to do that? I don't.
If not, you could put out a wee comment in the chat box. And hopefully it wasn't too painful listening to your own voice. I always hate that when I'm hearing back a recording, but you sounded great to all of us, so just to reassure you. So we'll leave Lisa to put in a comment if she can in the chat box. And I think that's us coming to the end of the session now. And just to round up, I'd like to thank all of our presenters today. I know this isn't an easy job coming on and presenting, especially to such a big audience, because at one point we had over 230 people on the webinar. So thank you so much for all of the presenters who shared their experiences and reflections on the session today. I think there was lots of good examples shared. A lot of this is not new and it's not rocket science, but what we have seen through this work is when we can do it reliably well, and usually starting really small scale, as many people talked about today, using a very structured approach, bringing teams on with you and bringing people alongside you and taking a real person-centred approach to this, we can really make a difference. And we heard the huge impact that those small changes are really making. So thank you all for doing that today. We have one last ask before you leave the session today, which is that you complete a very short poll or in the chat box of what will you do next, having heard everything you've heard today. What will you do next following this session? So just take a minute or so to do that and just pop them in the chat box. So we're seeing examples of where people will share some of the information that we shared today and share some of the ideas, incorporate ideas into their own workplace, share with wider staff members and share with their team. So thank you for doing that, and together I'm sure we can all make a difference if we're all doing this. So in terms of next steps, we will be having some further webinars planned in this series. So as you may be aware, the new dementia sign guideline is due to be published on the 28th of November, and on Thursday the 7th of December we will be sharing a webinar on that launch. And you can register now, and the link will be going in the chat box as I speak. So if you haven't already registered, I would encourage you to do so. It's going to be a great session. So thank you. And we just have one final ask, which will only take 2 minutes, which will take us up, still finishing on time, to complete the very short evaluation survey, which is now in the chat box. So if you could just click on the link, and if you can answer the evaluation questions for us. In true improvement terms, we always want to learn from our sessions, and if you can provide any feedback that can help us for our future sessions, that would be brilliant. Thank you. And I see one of the comments in the chat box that the link won't open. We have tested it out and it appears to be working for some people, but we can always email it afterwards if you're struggling to open it in the Teams call. Yeah, others are able to open it, so I'm not sure if there's just an issue with Teams for some people. And I see a few people have asked for a certificate of attendance, so we can look into that as well. So we will be sharing the resources from today's session, the slide deck and the link to the recording, and we can include an attendance certificate for people who would find that helpful. And we'll look forward to seeing you at our next webinar in December. Thanks everyone for attending today, and for all our speakers, and for all of the organisers in the background as well, who have done a huge amount of work to make everything run smoothly. So thank you.